time out of your day to have a listen. Have a listen to the webinar. I hope that you learn a lot from it, and I'd like questions, if possible, to be held for the end of the webinar because it's only on one topic. So hopefully we can just save questions for the end. I'm very happy to answer any questions you have. I know there probably will be a few. So just if you don't mind just saving them for the end, that'd be great. I've left time for that. So, but apart from that, I think we're ready to jump straight into things. Just firstly, a little bit of background about me and maybe why I'm someone who is a little bit more qualified to speak about ACL injuries. I actually studied physiotherapy first and then did a master's in high performance sport after that. And I really like having that double background in both exercise science and physiotherapy because I feel that it really allows me to work with ACL clients very well from day zero all the way through to return to play. Because I know, at least in Australia, a lot of physios are taught very well about the sort of early to mid stages of the ACL rehab. But when it comes to late stage rehab and return to play, a lot of that is fairly advanced training. And often in our physio programs, we're not taught much about that area. So with my background in strength and conditioning as well, I feel like it's allowed me to help work on particularly the second half of the rehab process and become an expert in that area of things. So that's a bit about my background. I'm really passionate about trying to bridge the gap between rehab and performance, which is where ACLs obviously fit in a lot. And also like injury prevention, because we're seeing so many ACL injuries these days. It's really quite shocking, some of the statistics that are coming out. So I'd like everyone to know a bit more about what you can do as a physio or a strength and conditioning coach to help prevent ACL injuries too. So for me though, I sort of fell in love with ACL rehab for a few reasons. I actually did my own ACL back in my first year of uni, and that led me down the path of learning more and more about it. And then for me now with my background, I find it's a really nice mix of both physio and strength and conditioning, as I mentioned earlier. It's also a really nice mix of both the art and the science behind it, because while we do have a fair bit of research on ACLs, we obviously don't have the answers for everything through research. So I find there's a real art to the rehab process as well, and it gives you that creative autonomy to make decisions as a practitioner to try to help your clients. And every single client you see or patient you see is different. So there's a huge art to the way you do your rehab, and I really enjoy that. And as I mentioned too, I'm very passionate about reducing the risk of ACL injury because we're seeing so many these days. So that's sort of why I've fallen down the area of ACLs. And I worked for many years in a clinic in a high performance facility, actually just seeing ACL clients for many years. So that's all I saw, and I hopefully can pass on some pearls of wisdom from learning that to you guys. Another thing about me, if you've heard of Physio Network before, I'm one of the co-founders of Physio Network too. So there's 3 of us, and I'm one of them. So yeah, that's a little bit about me. Enough about that. Let's get into what we're going to chat about today, which is obviously non-surgical management of ACL injuries. A very hot topic, a very popular topic, and one that I'm happy to share as much as I possibly know about and have learned about over the last 5-10 years of my career working with ACL patients. So today what we'll cover quickly is we'll have a little look at the research, the high quality research that we do have on this topic. There isn't much, so it's only a couple of really key papers we'll have a look at. Then a really important topic is copers versus non-copers. How can we identify who a coper is? Can you move from being a non-coper to a coper? How can we try to work that out early to put your patient on the right path for their management? So we'll go through that. We'll also have a look at what does the rehab process look like for a non-surgical management compared to a surgical management rehab, and whether there's differences, what those differences might be. And finally, a really extra hot topic at the moment is ACL healing, whether it can happen, how often does it happen, what are the factors that might affect the chances of it happening. So that's what we're going to cover today. I hope you can take a lot away from it, and yeah, it's useful for your patients. So as I mentioned, obviously non-surgical management is a really popular topic, especially in the last few years. There's more and more people talking about it, which is fantastic to see. I know in Australia, and it's very common all around the world too, that still the typical response when someone does their ACL is that, okay, you need to get surgery. And what I hope that by the end of this presentation today, you might realize that surgery should not be the default response for an ACL injury. It shouldn't be, okay, you've done your ACL, when are you booking in for surgery? It needs to be seen as obviously an important option that's available to people, but it shouldn't be done 100% of the time. It really needs to be dependent on a lot of factors. So I can see that, yeah, just in the last few years, things are starting to change. People who are very up to date and well informed are starting to learn a lot more about it. But unfortunately, the general public, and when you watch sports and different sporting events, if a player does their ACL, straight away the commentators will say, oh, he'll have to get surgery and it'll be 9 to 12 months rehab. Everyone just feels like that's the way it is. But as we're learning more and more about this topic, it might not be so black and white. So hopefully we can share a bit today about this and why those beliefs should be changing. So just to start off with the two key papers on non-surgical management of ACL rehab versus surgical, there's only been, it's crazy to me, there's been hundreds of studies done on which graft type you should use for your reconstruction, whether it's hamstring, patella, quadriceps tendon, or even synthetic. There's been hundreds of studies on this, but actually only a couple of high quality studies on whether surgery is needed in the first place. So it blows my mind that there's such a imbalance between the amount of research on how to do surgery versus whether surgery is needed in the first place. So today, let's have a chat through the two high quality papers that have been done, RCTs that have been done on surgical versus non-surgical management of ACL injury. So the first one you may have heard of before, it's probably the better known one. It's called the Canaan trial, and it was done in 2013 by Frabel et al. There's the title for it. I put in the notes there. I would highly recommend you typing that one into Google or taking a screenshot to save it for later to check out the paper and having a look for yourself. But I'll summarize sort of what was done and the key results now for you. So essentially, they took 121 young active adults, so people that are playing sport, not just people who don't do much sport and are only sort of doing gym or running. They actually took people playing sport, multi-directional sports too. And essentially they assigned half of them to get surgery very quickly, and the other half were to do rehab with the option of getting surgery later if needed. And both groups did the same sort of structured rehab. It was good. They tried to control for the fact that both groups actually went through a structured rehab process with a physiotherapist, which is obviously a critical element in the success of both, rehab from surgical and non-surgical methods. And they followed these 121 young athletes for 5 years and looked at some of the outcomes. And we'll talk through them on the next slide now. Here's a screenshot from the results of the paper. Essentially, the summary is that there was actually no difference between groups in terms of all of the different factors they looked at. None of the differences were statistically significant. So everything through to just symptoms in the knee, through to like returning to their pre-injury activity level. So if they played soccer before at this level, were they able to get back to playing soccer at that level, or whether it was basketball or rugby or whatever they were doing beforehand? Was there a difference between the two groups at getting back to the level they were at before? And for all those outcome measures of symptoms, activities of daily living, function, returning to pre-injury sport, whether they had meniscal surgery following, whether they had osteoarthritis, all of those variables were equal between groups, essentially. There was no statistically significant difference. So a really eye-opening paper, and one that really, questions whether we should be going down the surgery route as often as we are. So a very interesting one. I'd highly recommend you checking that paper out. The next high quality RCT on this topic was a more recent one. It was done just last year. It's called the COMPARE trial. Again, I highly recommend you typing into Google COMPARE trial ACL 2021, and you'll be able to find the paper itself. But in this one, similar structure for the paper. They split a group of 167 athletes into two. 85 were put into early reconstruction, and 82 had rehab with the option of getting delayed reconstruction if needed. And as you can see from the graph that I put there, which is their IKDC scores, which is the International Knee Documentation Committee, a very thorough measure of lots of different things to do with the knee, from symptoms, functions, return to activity levels. It sort of covers the whole gamut of things that you'd want to look at in a patient with the knee. As you can see there, at the 12 to 24 month mark, there was no statistically significant difference in their scores in this test, in this assessment tool. So Just to help you understand what the IKDC scores are measured by, the higher the score, the better. So as you can see from the graph there, at the 3-month mark, the group that did rehab instead of getting surgery right away actually had better scores in the beginning. And that makes sense because, after surgery, for the first few months, you obviously, have a lot of rehab to do and the knee's in pain, the knee's swollen, and it's still adjusting from the surgery. But after that point, you can see that they crossed over at sort of the 6-month mark where they were pretty much identical. But following on from there, from the sort of 12 to 24-month mark, there was very little difference between the two groups in their IKDC scores. So quite an interesting one to see, very little difference after 1 to 2 years there. An interesting finding too from this paper is that 50% of the people that were, did rehabilitation first did not end up needing surgery in the end. So that's 50% of people that avoided surgery who normally would have gone down the surgical pathway. And I guess you can look at that two ways and say, oh, well, half of them needed to get surgery anyway. But the way I see it is, well, there's like 50% of people that did not need surgery. At the moment, most countries are sending, 90% plus of people for surgery automatically. So it's quite interesting to see this paper showed that of those who did rehab first, half of them didn't even need to end up getting surgery in the end. So quite an interesting finding, in my opinion. The last dot point here is about their return to the sport they were doing before. And while there was a slight favor in the group that was surgery to getting back to their sport, it wasn't statistically significant in the study. So 43% in the surgical group got back to the sport they were doing before versus 31% in the non-surgical group. So yeah, quite an interesting paper. Highly recommend you check it out, type it into Google and have a look at yourself, but there's some of the key results. So what does all this mean? We've got these two papers. Obviously, we need a lot more research. But for me, what these two papers shows is that it's not so black and white. We shouldn't be thinking, okay, everyone needs to get surgery after they do their ACL. Perhaps there is a subset group of patients that can go quite well without surgery. We need more research, and we need more high quality research too. But for me, the biggest takeaway is, if you're unsure about something because we don't have much research on it, the default response should not be to get surgery. I don't understand why for ACLs, it's like, okay, the default response is go get surgery. But if someone had an elbow injury or an ankle injury or an injury to anywhere else in the body, surgery is the last resort normally for that. So why is it different for ACLs? And I find that quite an interesting psychology to think about for this topic. Okay, so if we're not getting surgery, what is best practice management for ACLs? This is what the research shows and what I found working with many non-surgical patients too. But you're looking at doing 3 to 6 months of structured, progressive, supervised rehab. And each of those words are important. The rehab needs to be structured. It can't just be random exercises with no structure at all. It should be progressive. They should get harder. You should add load. It should add, the sort of the challenges to the knee should be greater at week 4 versus week 1. Should be progressive. And then supervised results are shown to be better when working with a physiotherapist compared to doing everything on your own. So that's what we should be doing. Do that for 3 to 6 months and then reassess how your patient's going. Are they having any instability episodes? Are they progressing back to being able to do the activities they want to do, whether that is going back to just running or going back to playing sport of some kind? Are they progressing towards that goal? And are they having any hurdles or obstacles getting back to there? And you have a good idea normally, in my opinion, from what I've seen, at around the 2 to 3 month mark, you'll have already quite a good understanding of how the athlete's progressing and whether they're more or less likely to be a coper. And we'll have a little talk through now of what being a coper means and what sort of factors we're looking at for that. But just quickly first, it's really important to understand that you can't judge two patients the same in their ability to get back to what they want to do without an ACL, because obviously sports and different activities place hugely different demands on the knee. So if you're working with someone who just wants to get back to, for example, riding a bike, that's completely different to working with someone who wants to get back to playing football or basketball or a multi-directional sport with a lot of agility. So not all sports are created equal, and it's super important that you take that into account when you're working with your patient. I wouldn't be telling my patient who just wants to go back to maybe doing some gym work, that they're as likely to do it without an ACL as someone who wants to get back to playing football or basketball, which is going to be a bit harder. So it's important to understand, look at the patient in front of you. What do they want to get back to? And, understand that some people will be more likely to get back to their sport depending on the demands on the knee in that sport. Copers versus non-copers. This is obviously a really, really important area. This is probably the most important thing to try to understand when you're working with a patient. If you can identify early whether someone's likely to be a coper or non-coper, or know what signs to look for, you can help send them down the right pathway for their management early. So what a coper? Well, what is a coper? All it means is someone who's able to function well without instability or any sort of instability episodes without an ACL. And how do we measure that? It's not a perfect science at the moment. We have a fair bit of research coming out on the factors that might affect someone's ability to be a coper, which I'll go through in the next slide. But how can we find that out, and how can we know? It's really a matter of tracking your patient, weekly when you're working with them, and understanding how they're going, and communicating with them a lot about how they're feeling and whether they have any instability episodes and things like that. So we'll have a little look through now of factors that might make someone more likely to be a coper or less likely to be a coper. So we'll start with the factors that make someone more likely to cope. Obviously, the nature of their knee injury is a hugely important one. So have they had any other concomitant injury to the knee? That's a big one. So if someone just does a clean ACL rupture and they haven't injured their meniscus, they haven't injured their MCL or any other tissues, they're more likely to end up being a coper than someone who has injured those other tissues in the body. The research also shows that if the patient is a bit older age, so they're not under 21 years old, and if they're female, those two factors are more associated with being a coper too. We don't quite understand why just yet, but perhaps maybe because younger males in particular are sometimes more likely to be playing those really multi-directional agility sports than sort of older age and females in some instances. So that might be one reason why. Another one that I've found personally, anecdotally, if someone has a really high level of physical function in the lead up to doing their ACL, if they're really strong, they've been doing like a whole preseason of training, they're in really good shape, then when they do their ACL, they're often in a better position to bounce back from it than someone who maybe is quite weak and hasn't been training much in the lead up to their injury. Something really important to look out for is how the patient responds in those first 3 to 4 weeks after the injury. You can get a lot of clues early whether someone is likely to be a coper or not from how they respond. So if they're sort of telling you, look, it doesn't feel too bad, like, yeah, it's a bit swollen, but I'm walking around okay, I'm not feeling it give way on me, it feels pretty normal, it's just a little bit sore, a little bit swollen, but otherwise I'm feeling pretty good. That's quite a good sign that someone is already on the pathway to potentially being a coper, compared to someone that's telling you that, they're in heaps of pain, they can barely take weight through it, their knees giving way on them all the time. That might mean that someone is, potentially more likely to not end up being a coper. A big one there that I've mentioned before is the number of instability episodes they have. If someone's had just one episode or not even one, and it's been 2-3 months since their injury, and you are trying to challenge the knee more and more and more, but they're still not having any instability episodes, that's a really promising sign that they might end up being a coper. So what's really important in that is that you are challenging them. If you're only ever doing stuff in the gym and no sort of landing work, no running, no change of direction once they're ready for it, then you can't really judge whether they're likely to be a coper yet, because you do have to challenge the knee and try to progress them back to what they want to be able to do, which is normally their sport. But if they're doing that and they're not having really any instability at all, then that's a very good sign that they are likely to be a coper. And that final one I've mentioned there is more about the psychosocial side of things. As we all know, when we work with patients, some are very fearful, worried. So if you're working with someone that keeps telling you, "Oh, I'm just really scared it's going to give way on me," or I read about someone who tried non-surgical and damaged their meniscus, "I don't want to do that, I'm really worried about that," and they're very fearful and fear avoidant with their movements. I've found that those people are less likely to be able to cope than someone who is quite positive about things and is willing to give it a go and to try their best with their rehab and And is when you educate them about non-surgical management, they're very receptive and they're really interested in trying it. So that's a final factor there. And obviously on the other side of the coin, the reasons that might make someone less likely to be a coper, it's essentially the opposite of everything we just went through. So if someone has several different concomitant injuries to the knee, they might have done their medial meniscus, their MCL, they might have had a tibial plateau fracture as well, and they've done their ACL too. That person's probably less likely to be a coper because they've obviously had such a severe injury to their knee and they have a lot to deal with there. The opposite of obviously older age and female is younger age males, maybe people who are super active and not willing to, I guess, have a bit of a break from their sports, and they try to do too much too quickly, and have instability episodes. That could be a factor. And then the rest of them are dead opposites of what we just went through before. So if someone just before they've done their ACL, they're really untrained, they're very weak and almost a bit unstable in the first place. If they have really poor function in the weeks following their injury, they're really struggling a lot with it. If they're having multiple instability episodes, even just turning around the corner in their home and really light things they're doing, but their knees giving way on them, that can be a sign that they're not likely to be a coper as well. And then, as I finally mentioned, someone who's very fear avoidant and very worried about their knee is less likely to be a coper too. So have a look at this slide. Definitely take a screenshot of it. It's some of the clues that you might be able to use to help identify if someone is more or less likely to be a coper. Obviously, there are no guarantees here. You might tick off everything on the left side there and still end up, having several instability episodes and, end up needing surgery in the end. But these can be some hints and clues that the research shows and that I've found in my clinical practice that might lead you down the right pathway there. This is a common question I get too. Once someone is labeled as a non-coper, that doesn't mean that they're stuck as being a non-coper. I've worked with several patients that in the first sort of 4 to 6 weeks post their ACL injury, they had, 3 or 4 instability episodes. But as we kept doing their rehab and they got stronger and their neuromuscular system became better and better equipped to add stability to the knee, then they ended up having less and less to the point where they had no instability episodes anymore. So it is really important that you don't box someone into being a non-coper and think that they're stuck there forever. They definitely can move across the spectrum as their rehab progresses. And that's why it's super important to at least give it 3 months minimum of rehab to see how someone moves along that spectrum. That's why I mentioned before, 3 to 6 months is normally what I would look at as a gold standard. In terms of the actual rehab you're going to do with someone non-surgically compared to surgical rehab, it's a really common question I get. Is it any different? And the answer really on the whole is no, it's not really different in terms of the way you would progress things. It's just that the time frames are often a lot quicker for non-surgical compared to surgical, because obviously with surgical rehab, you have to respect the healing graft and the healing tissue. So you can't do certain things at certain times because the ACL is ligamentizing and it's going through that process. So I've found that the actual structure in terms of the way you progress things, it's going to be really similar. It's just that you can squeeze it into a 3 to 6 month time frame compared to perhaps a 9 to 12 month time frame. And that's sort of what I've found. It's roughly about half the time it can take to rehab someone who is a coper to get them back to sport compared to someone who gets ACL surgery. The only thing that might be a little bit different, obviously, as you'd all know, the hamstring helps protect the ACL. It's what we call an ACL agonist. And that's because it attaches on the back of the tibia. So when the hamstrings contract, it pulls on the tibia posteriorly, just like the ACL would stop the tibia from moving anteriorly. The hamstrings can help function in that way too. So if you don't have an ACL in there, I tend to try to put a little bit more emphasis even than normal on hamstring strength, just to support that knee, to try to reduce that anterior tibial translation that sometimes can result in meniscal injuries if it's left unrestricted. So that might be the only way that I sort of tweak my rehab, apart from reducing condensing the time frames down for the rehab. For me too, I think that doing non-surgical rehab is a true test of the quality of your rehab, because you've obviously lost a major stabilizer in the knee, in the ACL. So you're going to be relying more on your neuromuscular system to add stability to the knee. And so therefore your rehab needs to be spot on, because you're essentially placing a bit more onus on the muscles to, switch on at the right times to support the knee and add stability there. So I find that quality rehab is perhaps even more important potentially in non-surgical rehab. And that last point there is essentially to sums up why there shouldn't be much of a difference between non-surgical and surgical rehab, because if you get surgery, the same sort of things that reduce the stress on the ACL graft are going to be the same things that reduce stress on the knee if the ACL isn't there at all. This is a really common question I get. Sure, okay, I can try non-surgical, but what if I'm working with someone who wants to go back to soccer, basketball, any kind of multi-directional sport that requires a lot of agility? And can you do it? You certainly can. Obviously, it's not 100% success rate, but that's the same for surgery. I'm not sure whether you've seen some of the research on the rates that people return back to their sport after surgery. It's nowhere near 100%. It's often a lot closer to 50% of the time someone gets back to the sport they were doing before after getting surgery. So there's no guarantees on either side of the spectrum. It's not like you're more likely to get back to surgery, get back to sport with surgery compared to getting back to sport with non-surgical. The rates are quite even, as I showed you in those two papers earlier that we looked at. So it certainly is possible. And there have been some really high level case studies with elite athletes that have gotten back to sport without surgery. I've listed a few there. There's a brilliant paper. I would highly recommend you check it out. It's super interesting. It's by Whaler et al. From 2015. It's about an EPL player that did his ACL and returned back to the EPL 6 weeks later after doing his ACL. A phenomenal turnaround time. Really interesting one. Again, type it into Google, Whaler et al. 2015 ACL EPL, and the paper will come up. But yeah, phenomenal turnaround time. 6 weeks is the fastest I've heard of. Personally, I've worked with an athlete, which I'll show you in the next few slides, who I got him back to sport in 3 months. That's the quickest I've managed in my time. He just responded really well to things. Typically, it's more around close to that 6-month mark that I've found to returning people back to sport, though. But that Whaler et al. Case study is a fascinating paper to check out. If you follow your basketball, there's a player called Juan Blair in the NBA who played in the NBA without an ACL in both of his knees, not even just one knee. Both knees didn't have an ACL. So really interesting one. And then closer to back home for me in Australia, there's a player in the National Rugby League, Peter Wallace, who played for many seasons without an ACL too. So just a few case studies listed there. There are more, and there's more and more coming out as elite teams are being more prepared to take on the risk and following the path that is a little bit less traveled by. And I think that's the biggest fear for physiotherapists working in elite sport is if they try non-surgical and it doesn't go how they might have liked, then they probably fear potentially, losing their job or, being, having some really negative criticism from the coaches, because the main path everyone's always done in elite sport is to get surgery. So to steer away from that and try something new and then it not to go well, you're more likely to sort of get in trouble from the coaches if it doesn't go well compared to doing surgery and not going well. So I really hope that we do see more and more cases in elite sport of people going back to sport without surgery. So it starts to become more and more widely accepted as a genuine way to get someone back to sport a bit faster. To bring in a case study of one of my athletes here, his name's Josh. That's me and our other physio. I worked with a semi-professional rugby club called Gordon Rugby Club here in Sydney, Australia. And we work with Josh, and I have a really cool story about him and a great non-surgical outcome. So he did a whole preseason for 4 or 5 months leading up to the first trial game for our rugby season. And unfortunately, in that trial game, he had a player fall on his leg from the outside and push him into a lot of valgus, and he tore his ACL in the very first game of the season. So he was heartbroken. He'd done the best preseason of his life. He was in great shape, the fittest, fastest, strongest he's ever been. And unfortunately, in that first trial game, a player caused him to do a contact ACL injury. So he was shattered. He thought his season was over. But me and the other physio came together and we chatted with him about the option of potentially trying non-surgical management with him. And he was really open to the idea. He really was responsive to it. He was really happy to give it a go. and he had very few psychosocial red flags. Or yellow flags. Sorry, he was really positive about it. He wanted to get back out there as soon as he could, and he was on board with doing his rehab as strongly as possible. So he did that with us, and we had a really successful rehab. Even just 1 or 2 weeks after his injury, he was able to do multiple single leg squats to a box at 90 degrees, and he was crushing it really early, which was a great sign that he might have been a coper. And he actually got back on the field that season, played in the last sort of 6 to 8 games of the season, played in the grand final, and that's him holding the trophy there after winning the grand final. So a really nice story of a great outcome for non-surgical management. And I'll just show you on the next slide a quick video of him. This is in his first game back after doing his ACL. So 3 months from the day where he did his ACL. This is 3 months later, him returning back to the field. The video quality isn't perfect, but you'll be able to understand what I mean. He scores this try in rugby. I'm not sure how many of you know rugby very well, but for those who do, you'll be able to appreciate it a little bit more. But I was played a couple of times. It was his right knee that he has no ACL in, and you'll see him catch the ball, not the first ball, but the second pass that's done. He catches it and steps off his right leg that doesn't have an ACL and scores a great try off it. I'll just play it for you now. You can have a little watch a couple of times. I'll play one more time. So as I mentioned, it's his right leg. He catches the ball and then pretty much immediately steps off that right leg straight away. So he's got a lot of cognitive demand in that moment, but he's able to, have a look at where he wants to go, catch, step off that right leg, plant hard off it, and cut through the defense to score a try. And that's all with no ACL. This is 3 months from the date of tearing his ACL. So yeah, just a really nice story of one of my athletes. Obviously, not all stories of non-surgical are like this, where he gets back in 3 months and has no problems and it all goes well. Some don't go that way, but I just thought I'd share that with you as a nice case study of one of my patients. A really common question I get is, okay, if I'm going to do non-surgical, what are the long-term implications of that? And am I more likely to end up tearing my meniscus or have knee osteoarthritis? And there's been a lot more research on the osteoarthritis front, which I'll cover in the next slide. In terms of the meniscal damage question, there has been some research on it, but we really don't have much that's really used high quality rehab. And by that, I mean structured, progressive, supervised rehab, like I mentioned earlier in the presentation. But there is a nice editorial in the British Journal of Sports Medicine that looks at, is early ACL reconstruction needed to prevent further meniscal injury? And it is a common myth. From the research we do have so far, there isn't anything really to suggest that is the place. We need more and more. We don't really know too much either way right now, whether it is more likely to lead to meniscal injury, but we certainly can't have the belief that you are more likely to do your meniscus if you don't get surgery, because that isn't reflected in the research at the moment. We need a lot more there. There isn't anything at the moment to really suggest that is the case that's used proper high quality structured rehab. So it's a bit of a to be confirmed one at the moment, but if someone ever tells you, no, like I'm certain that this is the case, well, the research just doesn't support that at the moment. So it's one to watch that in this space. On the other hand, we have a ton of research looking at the rates of osteoarthritis for people who did get ACL surgery versus didn't. And the great news is that there is no difference in outcomes shown in almost every study looking at someone who either did get surgery or didn't, and their rates of osteoarthritis at 10 years post-injury, 20 years post-injury, even all the way up to 37 years post-injury. We have research in lots of different timeframes, and there seems to be no difference between rates of osteoarthritis. So that's a really common myth that you are more likely to get OA if you don't get surgery, but there is zero research to support that one, and it has been studied quite well. So it's more likely that the initial injury itself is the thing that's linked to getting osteoarthritis in the future, rather than whether you get surgery or don't get surgery afterwards. And it is, on this note, it is important to recognize that surgery itself is highly traumatic thing for the knee. You know, they're drilling through bone, they're taking out tissue, healthy tissue, and replacing it to use as the ACL. It is a traumatic thing on the knee. And that's why in some of the research it actually shows that you're more likely to have OA after surgery versus non-surgical. So just an important one to always recognize that surgery is like having another major injury in the knee. A really hot topic, especially in the last year or so, is, well, can the ACL heal? I'm sure some of you would follow people who've posted about this on social media. I'm so glad to see it getting more and more coverage at the moment, that, you know, the ACL can in fact heal in some cases, and it might be a lot more often than we're taught at uni. I don't know about everyone on this webinar, but when I was at uni, I was taught that the ACL can't heal, it doesn't get any blood supply, and that's that. Well, turns out it's a little bit more nuanced than that, and it definitely can heal in some cases, and we'll have a little talk through when that might happen. Obviously, the picture I've got here is actually from Mick Hughes, someone who's a real expert in ACL management, who I definitely recommend following as well. You can see the initial scan looks nice and ugly. The ACL is obviously completely ruptured there, and the tissue's a bit all over the place, lots of swelling. And then 4 months post injury, you can see that the fibers of that tissue have really started to heal up nicely along here. I'll show you a case study of one of my clients too in a second. So here's someone that I worked with. He followed the cross bracing protocol, which I am actually not aware whether it is used much outside of Australia, but I'll talk you through it anyway. It's a relatively new procedure that's used to help manage ACLs non-surgically and to try and encourage healing of the ACL. And what it involves is being put in a progressive range of movement brace over a 12-week period, starting being held fixed at 90 degrees flexion and gradually over that 12 weeks, allowing more and more extension until the point where at the 12-week mark, allowing it to go to, you know, full knee extension. And the patient also has to be non-weight bearing for the first 9 weeks of those 12. And the whole idea behind this is that the sports doctor, Tom Cross, who came up with this cross bracing protocol, he tries to put the knee in a position that encourages ACL healing. And by non-weight bearing too, that can also encourage it in some ways too. You're trying to not put any undue stress on the area as it's healing. So one of my patients actually followed this protocol, and you can see in these scans on the left, obviously that's post-injury. You can see the ACL tissue there being ruptured, and then that's 6 months later, his scan, you can see really quality dark tissue here. And obviously the darker the tissue, the healthier we're looking at. You know, there's less swelling and less of that white sort of swelling and inflammation in the tissue. So really high quality result there. And he was able to return back to sport about 6 to 8 months after his injury with a healed ACL, which is a fantastic result for him. So in terms of how often it happens, we obviously don't have the answers to that right now. We don't know. We can't say it's going to happen. You know, we can give an average based off the limited research we have, but we just have such limited research at the moment on this topic that it'd be poor of anyone to try to put an exact figure on the amount that heal. But one thing's for sure, it's looking like it happens a lot more than what we're taught at uni, which is next to none heal. So from what I've seen in patients I've worked with and from what I've seen in the limited research we have to date, it's looking like potentially 20% plus can heal up really well. I'll show you a study in a second that shows it might be closer to 50, but from what I've seen personally and from what I've seen in the research we have, it's looking like potentially 20% plus will heal up quite well. There obviously are factors that affect that. One of them is the type of tear. So if you can imagine, if you have an ACL tear, sometimes the tissue is pointing in completely different directions and not even looking like it's going to line up at all. That's going to make it a lot harder for there to be union between the two tissues compared to looking at an MRI after ACL rupture, and the scan looks a bit more like this, where there is obviously separation and rupture of the tissue, but the tissue is almost like pointing towards each other and closely aligned, and there's less sort of union that needs to be done. So that is an important factor in how likely the ACL is to actually be able to reheal itself. Placing a little bit of stress on the knee, the right sort of dosage, the right amounts, can also encourage healing by just putting a little bit of stress on the tissue and trying to encourage it to to come together to support the knee. Another factor that the research shows is people over 20 being more likely to heal than those who are a bit younger, which is an interesting one. And another final factor is sort of the less severe the injury is more likely to end up in ACL healing too. So if you've got someone who's done their meniscus or MCL, a tibial plateau fracture and their ACL, obviously there's a lot that the body has to prioritize there to try heal. That might mean that the ACL doesn't heal as well compared to someone who just has a clean ACL rupture. Some of you may have seen this paper get thrown about on social media recently. It only came out about 4 to 6 months ago. It's only an abstract at the moment, is my understanding. So take it with a grain of salt, but it's actually a secondary analysis of the Canon trial that we spoke about earlier in this presentation. And it showed a really stunning result in that by the 2-year mark, 56% of people's ACLs had healed, which is the highest ever reported in the literature so far. And as I mentioned, though, there really aren't many studies looking at rates of healing. So it is one of just a few we can look at, which might suggest that, potentially even potentially more than 20% of ACLs can heal under the right circumstances. So a really fascinating paper. Keep your eyes peeled for when the full text comes out so we can dig into it a little bit more. But the really interesting part of this is that the people whose ACLs did heal, they actually had better outcomes than those who had surgery. So if the body is able to sort of heal your ACL itself, you're more likely to have better long-term, medium and long-term outcomes than someone that has surgery. So I found that quite interesting, that if you can let the body do its work itself, then that's a really good sign that you're likely to have better long-term outcomes. And I would have loved to seen if they reported at the 6 to 12 month mark. Unfortunately, the paper only reported on the 2-year mark and the 5-year mark. So it'd be great to know if that healing had occurred a bit earlier than the 2-year mark, because obviously that's quite a long time to wait for the ACL to fully heal. To sort of bring everything we've chatted about together today into some takeaway summaries, it's the main message I really want to pass on is that surgery should not be the default response every time someone does their ACL. It should be a lot more nuanced than that. You shouldn't be hearing that your patient's done their ACL and just calling up the surgeon to book them in. It shouldn't be like that. It should be that we follow that best practice management of rehabilitating them for 3 to 6 months, seeing how they're going, seeing how they're tracking. If you notice that around the 3 or 4 month mark that someone is, even though you're doing progressive rehab, they're still having multiple instability episodes, they're having real problems and they're not progressing much at all, sure, definitely send them off to the surgeon to see them to get an opinion. But we shouldn't be doing that immediately as a default response whenever someone does their ACL. It's what we see happening a lot, and I definitely think that should be changing. Obviously, from the last part of my presentation, hopefully I've shown that the ACL can heal in some cases and perhaps a lot more often than we thought. And finally, really important that you're not actually at greater risk of knee OA if you don't get surgery. And like, to bring a bit of balance to everything today, by no means am I saying that, you never need surgery. Hopefully I haven't conveyed it in that way. There are many cases where surgery is the right way to go. And so sometimes that is the case. I wanted to open up now to some questions. If anyone has any, please feel free to unmute and ask them. I'm sure there are a few from things I've said today. It can be on anything that I've covered or even potentially related content that I might not have covered today. So feel free to ask and I'm happy to answer them for you.
Doctor, good morning.
Morning.
Can I ask a question, please?
Yeah, sure.
Yeah, please. My name is Ali. Okay, I'm talking from Lebanon. Maybe some of the guys here share with me the same experience. In the Middle East, we have a small problem with the doctors that when an athlete has an ACL injury and they go to the doctor, the first thing the doctor said, you need a reconstruction. So this is a problem we have between the physiotherapist from one side, the patient and his doctor, and normally the patient or the athlete will go with his doctor's opinion, and we don't know how to deal with it. Like how to convince this athlete, okay, let's try to go for the non-surgical rehab process, or and on the other side we have the doctor opinion. So we are just in the middle. So I don't know if you have it in Australia and how to deal with it. Thank you.
Yeah, that's a great question. It's probably the most common question I get when I speak about this topic, and there is no easy answer. There's no trick you can use. We have the same problem in Australia too. A lot of people, while they will see a surgeon and see a physio, they often hold the surgeon's opinion in much higher esteem than the physio. And in Australia, some of the younger surgeons are starting to realize that non-surgical is possible, and they're a lot more open to referring to a physio and then potentially seeing the patient in 3 months and following up with how they're going. If the system over there in your area is that they go straight to a doctor and they see a doctor and you don't even get a chance to communicate with them before they go to the doctor, that makes things really tough. I would recommend as much as possible trying to have a conversation with them either before they see the doctor or around the same time that they go to the doctor, and explain some of the stuff that I've mentioned today, that there are research papers on it that show that there's no difference in outcomes between surgical versus non-surgical. Talk about some case studies. You might be able to find a case study in the sport that the athlete is playing that you can use to tell them, oh, well, this player, do you know them? Well, they came back without getting ACL surgery to their sport. And just try to educate them as much as you can, because obviously they're going to receive a message from their surgeon or from their doctor that, you know, surgery is the way to go most of the time, because most of the surgeons aren't very up to date with this. So all you can really do is jump in there and try to have chats and conversations with them around the same time, educate them as best you can, and just let them know that whenever a surgeon sees a patient, it's hard for them to operate differently, because all they have as a tool to help the patient is to do surgery. They don't really have the other skills. And so it's important that they understand that there needs to be a balance between, the surgeon's perspective might be a little bit biased towards surgery because that's all they can sort of offer the patient. So my answer is educate the patient as best you can. Try to chat to them before they see the doctor and tell them, look, the doctor's going to very likely tell you this. Here's what the research says. Here's some case studies of athletes that have done it. And tell them we can always get surgery in a few months' time if you're not going well. Like we're not taking surgery off the cards altogether. We're just going to give it a go, give it a try, and see how you're going. And then if you need surgery, that's fine. We can go there. But if you can save your body the stress of having a surgery, then that's a good way to go. So I guess that would be my answer. I know it's a tough one, but hopefully that's helpful in some way.
Thank you.
No problem.
Yeah, doctor, I have a question.
Sure.
Yeah, doctor. So let's say a footballer injured his ACL, okay, an elite professional player injured his ACL. So how long will he take to heal his ACL? Like in your presentation, it was said that it'll take like 5 to 6 months. So after that only the post non-surgical management should take in place, or how is the procedure actually?
Which case study are you referring to, just to make sure I understand your question?
I mean, I just want to know in general. Okay, let's say
Sure.
the patient wants non-surgical. Okay, so how long should he
Yep.
how long should he wait for the post non-surgical management?
Sure. Okay, good question. Probably the first thing I want to clarify here is that you don't need necessarily the ACL to have healed by itself to allow you to go back to sport non-surgically. There's many people who have been able to get back to sport non-surgically, and you get a scan on them even when they've gone back to sport and their ACL hasn't healed, but they still have returned to sport. So that's probably the first thing I wanted to clarify. You don't need to see on MRI that the ACL is healed to allow them to go back to sport, because as I mentioned, the way you need to think about the knee is the ACL is one of the passive stabilizers of the knee. And there are many passive stabilizers of the knee. You have the PCL, the MCL, the LCL, the joint structures, the cartilage, the meniscus. All of that adds stability to the knee. And they're all passive stabilizers. The other side of the coin is the active stabilizers of the knee. And that essentially is the neuromuscular system. So if you can develop the neuromuscular system well enough through great rehab, to be able to compensate for there being no ACL there, then you don't need the ACL to heal to be able to return back to sport. So to answer your question, it really is, at what point is the athlete's neuromuscular system functioning well enough to allow them to do the activities of their sport, whether that be jumping, landing, or changing direction, or whatever it is. If you're able to progress them through rehab and they're ticking off all those things without any instability, that is the point where they are ready to go back to sport. So it should be based on function of the athlete and not on a certain time frame. So I hope that answers your question.
And adding on to that, doctor, like let's say he's able to function like 80, 85, 90%. So when he's playing in like the professional matches, he shouldn't be playing like the whole 90 minutes, right? Like he should be subbed in, right? Like after some point, because as you told, it won't be 100%. Though he's able to play, should at least play for a couple of minutes. I mean, like 50, 60 minutes, or like depending on his severity, right? So
I would treat it the same way I would with someone coming back from ACL surgery. Should be a graded return to play. So starting off with obviously finishing all your rehab and doing all your your work with your physiotherapist out on field, then going back into some parts of training, but not all of training, then building up over time to doing 100% of training. Then when you go back to the actual competition, maybe starting off by only playing 15, 20 minutes the first game back and building that up over time. But there's no reason that they should be limited long term from playing a full game. As long as you're do a graded gradual increase in their playing minutes, that's the most important thing there.
thank you so much, doctor.
No problems.
Hiya. Am I audible?
Yes.
Hi, my name's Rashmi and I'm speaking from the UK. I just wanted to ask about your opinion and your experience and where to place eccentric exercises in like the loading program for ACL rehabilitation, and if it's like any different from the cross bracing method that you explained earlier.
Yeah, sure. Well, I mean, that's obviously a fairly broad question, so hard to summarize, but I would use like eccentrics throughout the entire rehab process, really. Obviously, you're not going to be doing really heavy, high intensity eccentrics early in the rehab process because the knee might not handle it, but it's all about the intensity and the load you're putting on the knee. I wouldn't just be doing only isometrics in the beginning. I'd just be varying the load and still doing eccentrics from the very beginning, because we know how important eccentrics are for the muscle growth and muscle strength. So I use eccentrics the whole way through. Maybe you're referring to really heavy eccentrics, maybe 2 up, 1 down, and that I would probably be saving for the mid stages of the rehab when you're really trying to work on muscle strength. So for ACL surgical rehab, that might be some sort of the 3 to 6 month mark, whereas for a non-surgical rehab, that might be sort of the 2 to 4 month mark where I'm really using eccentrics heavily to try build muscle strength. In terms of how that fits in with the cross bracing protocol, the hardest part about the cross bracing protocol is that they have those 9 weeks of non-weight bearing, which means that their muscle tissue, as everyone here would know, starts to drop away very quickly when there's no weight bearing happening. So you have to overcome muscle atrophy in the first parts of your rehab, and that's where eccentrics can be super useful because they are very powerful for muscle growth and very potent at building muscle. So I would use them as early as possible as they're allowed to, and just it's the load or the intensity that you're changing depending on at what point of the rehab they're at. I would never just rule out eccentrics completely the whole time. I would use them just with different loads or different intensities depending on what point that they're at in their rehab. So I hope that answers your question.
Hello. Hi, Timothy.
Hey.
I just want to ask a quick question that how important is that using a knee ROM brace for even when we are going for a non-surgical ACL rehab?
Sure, great question. If you're following the cross bracing protocol, it's essential to do it with a progressive range of movement brace to encourage ACL healing. But I've worked with many non-surgical ACL clients who haven't done the cross bracing protocol and haven't used a brace at all for the knee during their rehab. So it's really, there isn't much research showing whether it helps much at all. So I find a big one is it's down to patient preference. If they as someone who's a bit worried and is more likely to engage in good rehab because they're wearing a brace, then by all means, I'm happy for them to use it. But you don't want them to end up being at the point where they rely on it and they feel like they need it the whole way through their rehab or anything. It might just be something you use for the first month post-injury whilst they're a bit fearful, a bit worried, and then remove it as they get a bit stronger. But by no means do I make it mandatory. I don't think it should be mandatory. A lot of people are absolutely fine without one. So I guess that's my answer for you there.
Thanks you so much.
No
Good
worries.
morning.
Morning.
Good morning. This is Ghulam Physio. What you're talking about is really very interesting. I think it is going to be possible only when we are able to convince orthopedic surgeons. As friends have said, the first thing patients are going to take is the surgeon's words, okay, not physio's word. So to convince a surgeon, and surgeon saying to the player that you take some time, then we can go for the surgery, then I think what we are talking about is going to happen. And my another point is like, how can we do research, because with this limited findings, as well as when patients are like, they're like, players are like everybody, they're smart now, okay, so they know everything, and they are very anxious and we are very impatient to go to return to the play. They are, though you give them a program, they are never 100% honest about it. They try out their own things because they want to go back to the game quick. So like non-surgical healing, when you're going for that, so my understanding is this is really going to happen with the surgeon when they say the player that this can happen positive. That is what I understand. What are your comments?
Yeah, sorry, do you mind just quickly rephrasing your question just so I make sure I understand it properly to give you a good answer?
Yeah, I mean to say, like, rather working more on the players to convince about for the surgery, we should work more on the orthopedicians. And how are we going to do that with this limited findings, I mean to say? Yeah,
no, good question. It really depends on the relationship you do have with surgeons over there. I'm not sure whether in the UAE that you are able to connect and speak with surgeons, whether it be over email or over phone calls or even in person. But the better relationship you can develop with the surgeon that you're likely to be working with athletes, the better outcomes you're likely to have, because they'll be more open to trying non-surgical rehab with you and then referring between each other when needed. In Australia, most of the time we are lucky enough to be able to, in some ways, communicate with the surgeons, whether that be visiting them and talking to them about some of the findings that are coming out in the research and trying to almost gently educate them too. But you obviously need to go about it respectfully. You don't want to just be sending surgeons research papers and saying, oh, you should never do surgery, like just send them to me. That's not going to be received really well. It should be more that I'd love to work with this patient non-surgically, and if things don't go very well, I will 100% be referring straight back to you for surgery. But I'd like to give it a go with them because some research is coming out showing that you can manage well non-surgically. So I'd like to, and at the end of the day, it's the patient's choice. I know you said that the surgeon is weighs heavily on the patient's mind, but if you can get the patient on board as a physio with trying non-surgical, then that's gonna be the most important thing you can do, because the patient gets to decide at the end of the day whether they get surgery or not. So I think that's really key, is your relationship with your patient and your relationship with your surgeon, but just being respectful about it and working together rather than working in separate silos. I think that's really important to think about if you can make it happen.
Thank you.
No problems.
So, Doctor,
Any other questions? Yep, sure.
at what what are the signs, and at what time period would you consider sending the patient back to their orthopedist?
Yep,
And
great question.
when you say like this conservative method of rehabilitation is not working, you have to go back to your orthopedist? Like, what
Sure.
are the signs and at what time period?
Yeah, so great question. Like I said in my presentation, I normally like to give a minimum 3 or 4 months of rehab to see whether that person is likely to end up being a coper. As I mentioned, sometimes in the beginning they might be really struggling, but after the second month and the third month they start to turn a corner. So I think it's important to not send back too early. You can't judge after 1 or 2 months whether someone's likely to be a coper or not. You do need, I found, that minimum 3 to 4 month period. But the things you're looking for to potentially end up sending back to the surgeon are that you're doing progressive, really high quality, great rehab, but the patient isn't getting any better in terms of their level of instability. So they're telling you, no, I'm still feeling it give way on me. It's still, I'm even just walking around and turning a corner at home, I felt it give way on me the other day. And you're still getting that feedback from the patient that it feels unstable and it's not feeling very strong, even though you have persisted with, a minimum 3 to 4 months of good quality rehab. And you might also see objectively that they are still really struggling maybe with some of their jumping and landing and hopping work, and they're really not moving well, even though you've tried to build them up gradually to it. And they're just not quite looking right. They're not looking great objectively when you're looking at them in the clinic, and they're telling you that they're still struggling a lot. They're still getting a lot of swelling pain and episodes of giving away, despite giving a good 3 or 4 months of rehab a go. That's the sort of time where I would go, okay, it's maybe time to refer back and potentially look at surgery as a pathway here.
All right, thank you. Great presentation.
Thank you very much.
Doctor, is your presentation recorded? Like, will we get the presentation?
Yes, I believe it has been recorded for people, not only who couldn't make it today, but for people who did. I'm sure Dr. Falco can confirm, but it's been recorded, so I'm sure you'll be able to access it as well.
Yes, it's
Okay.
recorded
And
everyone.
Any other questions? If not, maybe while we're waiting for some questions to come in, I did want to mention that I'm really excited about coming over to Dubai in the end of November to do my full 2-day in-person course with Learnovate. I'm really excited to come to Dubai and present. I haven't presented there before. It's essentially a course that's going to teach you how to rehab an ACL client from day 0 through all the way back to return to play, and how to get them back into training and games. And I've obviously put a lot of work into this presentation. It's very up to date. I'm really excited to come over and present it in late November. It's very practical too. We do a lot of, it's probably half theory, half practical. We get up and look at return to play testing. We look at exercises for every stage of the rehab process. We look at injury prevention, anything you can sort of think about when it comes to ACL rehab. I've made a 2-day course on it, and yeah, I just wanted to let you guys know that I'd love to see you there. And I think Dr. Falke can also let you know about something too. But we've got a coupon code for the next 48 hours for anyone who's sort of been on this webinar to get a discount. Maybe he can give you a little bit more information.
So I have a question.
Sure, no problem.
Yeah, sir, actually, if there is a case, like, we convince the patient very hard for this conservative management, and then the patient is getting better, and his with the training, everything goes better with training and rehab. But while the performance, like, he's lacking the performance and strength in the field, and he's become more of phobic thing. So in that case, what can we do?
What was the last thing you said? Became more of a what thing?
Like his strength and performance, like in the field.
On field. Yeah, sure. That
But
really comes down. Yeah, I was just going to say that that really comes down to your rehab process and how good you are at actually progressing someone through their late stage rehab and return to play. And that's where hopefully my 2-day person course can really help with something like this, because I take you through how you can optimize muscle strength, muscle power, change of direction, sprinting, and things that are a bit more at the end stage of rehab, which many physios, unfortunately, just because we're not taught very well at uni about this stuff, they struggle with that last part. They think it's more up to the strength and conditioning coach to manage, but often there isn't a strength and conditioning coach that you can work with. So it really comes down to how adept you are at managing that part of the rehab process. So as a physio myself, I would feel like I am responsible for making sure that they are getting stronger and they are getting more powerful, and they are, working through proper progressions for return to running, returning to change of direction, and returning to training. So I feel like it should be on you to really try to make that happen. If you are doing all the right things, but the patient just isn't gaining any strength, they are still really struggling on field, even though you've done all those great progressions in your rehab, that can be a sign too that maybe the knee itself needs to be looked at by a surgeon, because the knee is holding you back, the actual joint is holding you back. But yeah, it really comes down to the quality of your rehab in that late stage, and that's in particular what I like to focus on in this 2-day course. Is I'm very big on the second half of the rehab process that physios often aren't as well trained in. So hopefully that answers your question.
Thank you so much, sir. Great presentation.
Thank you.
Sir, will we get a certificate for today's webinar?
That's one for Dr.
Yes.
Okay, if you can help. Yeah.
Yes.
Sir, I would like to ask a question.
Sure.
So what are the crucial points for a non-surgical rehab for an adolescent player who's just started and he's got an injury? So the thing is, they are very eager to go back to the sport, and in spite of instructing them or making a proper rehab program, they are just so eager and they just want to go back to place. So how would you throw some light on that?
Yeah, sure. Yeah, adolescents are an interesting group. If you remember from my slide earlier about what makes someone more likely or less likely to be a coper, unfortunately, it looks like younger people are less likely to be copers without surgery. So look, and especially if they're really young, like they're an adolescent, they've got so many years ahead of them of sport, and they probably want to be doing 10 more years of playing sport. With a younger person, I'm not going to just send them for surgery right away, but I will be a little bit more careful about potentially trying non-surgical with them, because the research shows that younger people, especially males, are less likely to cope well. So let's say you do end up sending them for surgery. I found the most important thing is to educate and set expectations early in the rehab process and tell them, look, this is going to be a minimum 9-month rehab process. No one should return back before that point. And here's why: because if you go back earlier than that, you're 4 times more likely to re-tear your ACL. And we know that once you re-tear it a second time, your chances of tearing it a third and a fourth time are much higher. And just set the expectations really early for the timelines of rehab. And it shouldn't just be time-based. You need to tell them, okay, 9 months is the minimum, but you also are going to need to be able to be strong on both sides, be able to be running and changing direction, and be able to do some of your training that you return back to your sport and participate in training, and tick off all of these boxes before going back to sport. And I think if you can chat with them early in the rehab process about this and set the expectations early, they're less likely to try to jump ahead and skip ahead, because they understand what's needed of them at every stage. That's probably the best advice I can give, is to create expectations early and help them understand what they need to be able to do before they go back to sport.
Okay, thank you, sir.
No problems.
Hello.
Hello.
First of all, thanks for your presentation. Second, can we use the non-surgical treatment for the patients younger than 20, like 15 or 16 years old?
Yeah, so that's a similar question to the one before. The research shows that those who are really young, under 21, are less likely to cope well without surgery. That is not 100% of the time, though, they need to get surgery. That's not what it means. It just means that they might not respond as well to conservative management, compared to surgical management. So it should be seen on a case-by-case basis. Really, I can't give a general answer. You should be looking at the patient in front of you, looking at what happened in their injury. Did they do other injuries to the knee at the same time? What are they trying to get back to? How are they coping so far? And having a collaborative decision, making a collaborative decision with them, their coach, their even their surgeon, getting everyone involved and working out an approach. So it really is a case-by-case basis. I can't give you a general answer that applies to everyone. So yeah.
Yeah, thank you so much.
No problems.
Hi, I'm
Hello.
Shireen. Hello. I have a question. First, thank you for the very informative presentation. And my question is, what is the most productive mobilization technique for the ACL? The most productive.
You say most productive mobilization technique in terms of like range of movement of the knee?
Yeah, range of movement. Yes, yes.
Sure. Yeah, good question. Obviously, this is most important in the first couple of months post-surgery than anything. I'd be looking at the 2 to 3 month mark. You'd really be wanting to have full extension back in the knee and at least 110, 120 degrees of knee flexion by the 2 to 3 month mark too. My first answer is going to be get rid of the swelling as quickly as you can, because the swelling is going to limit your flexion range of movement probably more than anything. So working on whether that's elevation, ice, anti-inflammatories, things to get the swelling down is going to have a huge impact on your flexion range of movement. In terms of extension, it's important that you avoid forcing the knee into extension and really overdoing it. I also find it useful not to try to leave the knee in like an extension stretch for a really long period of time, for like 5, 10, 15 minutes at a time. I actually find pulsing sort of in and out of those end ranges to be more useful than really long holds, because often the patient might get up after a long hold for 5, 10 minutes in near their end range of extension and get up and feel a bit funny and a bit stiff. So my main things are for flexion, get rid of the swelling as quickly as you can, as much as you can, and then simply just lying on your back and putting your foot in a plastic bag and lying on the ground and doing heel slides towards your bottom. Super effective. And then once you get it as far as you can yourself actively, then using your hands for overpressure to pull it a little bit more into flexion and just sort of almost pulsing. So pulling it in a bit further for just a few seconds, then backing off. And I find pulses to be much more effective than really long holds. They don't tend to aggravate or irritate the knee too much, which is really important in those first couple of months. And then in terms of extension, same idea, having a therapist just putting their hands on top of the femur and tibia on either side of the knee and just doing gentle pulses, pushing that knee into a little bit more extension, but by no means really high force or really fast manipulation or anything like that. Just gentle pulses for a couple of minutes at a time, and then having a break and doing a couple more. I found those to be some of the more effective methods for helping regain range of movement. So I hope that helps your question.